We're online.
Hello, everyone. Welcome to the second episode of the iHub. Good evening and hello to everyone. Welcome to the second episode of the iHub presented by the iCare Academy. First, I would like to introduce our distinguished panelists for tonight. We have Dr. Ajay Soni, Associate Professor of Ophthalmology from Penn State Hershey Eye Center in the US. He's a very good friend of mine, been friends for years. We usually see each other every year, but we're not doing that this year. Dr. Maha ElBasha, used to work together for so many years. She's an adult and pediatric strabismus specialist in Alexandria, Alex Eye Center in Alexandria, Egypt, and she's going to be my co-moderator for tonight. And over to Dr. Maha to introduce the rest of the panelists.
Today, we're honored to have with us Dr. Akmal. He's a professor of ophthalmology in the Research Institute of Ophthalmology. He's a very talented and knowledgeable pediatric ophthalmology, and we're really thrilled to have him, and definitely he will enrich our discussion. And last but not least, Dr. Kamshoushy. He's our star in Alexandria, and he's an assistant professor of ophthalmology. And we call him the genius pediatric ophthalmologist, and because he helps us in every difficult case. And back to you, Dr. Amr.
Thank you, Dr. Maha, for this generous introduction. Without further ado, we're going to go straight into the topics of tonight. We're talking tonight about pediatric ophthalmology, and we're mainly aiming for the general ophthalmologist. We're going to address situations that we face every day, not the rare kind of cases. It's going to be everyday situations. First, I'd like to thank iCare Academy for helping to arrange this and reaching this outreach for the audience listening to us tonight. So the first situation, this is a pretty common situation, and I'm sure every one of us have faced it, whether you're a pediatric ophthalmologist or a general ophthalmologist. You see a 2.5 years old child is not very cooperative in examination. He's crying a little bit, looking at the toys sometimes, but he's not really the best child in office. The parents come in, they complain that they recently see some strabismus, and they insist on that complaint, both the mom and the dad. Well, you examine him by all the means that you can do, and you still cannot see anything. You cannot elicit the esotropia or the exotropia in this child. So you do a fundus and the refraction, and we propose three different scenarios here. First patient would have a refraction of a +1 both eyes. Second patient might have a +6 in both eyes. A third patient with the same scenario would have a -2 in both eyes. Now, faced with this situation, complain of strabismus, but you cannot see the strabismus, you wonder what to do, what to say next to the parents. First, I would like to direct my question to Dr. Akmal and hear his insight about this. What points in the history taking, Dr. Akmal, you think would be relevant and you would ask about in this situation that might be of use?
Because it's most of the our practice we are facing with pseudostrabismus. I think more than 10% of the children coming strabismus clinic. And my first question to the parent that you are noticing the squint by yourself, or someone else has said that your child is squinting. Even a pediatrician, even the neighbors, if she insists that she is seeing the strabismus, might be intermittent, I should concentrate on near vision. I should point the infant or the child to look at the tip of the pen. If he has convergence excess, will appear. And the second step that we can insist that the child has no strabismus might be Dwayne with ortho primary position or brown, and the mothers, I mean, they insist that have the child that had sometimes strabismus, but we cannot elicit the movement in a 2.5 years old child, especially in Egypt. This is my scheme of work.
Of looking at such cases. Dr. Maha, we would like to listen to you. If you feel it's a pseudostrabismus, I mean, you see a child, you examine him, and you think, okay, that's pseudostrabismus, and you're comfortable with your diagnosis, what do you do to the parents? What do you say? It's pseudostrabismus, and you don't have to come back for follow-up, or you would still follow up these patients?
No, definitely I would follow him up very closely, actually, because there have been lots of reports about patients having pseudostrabismus, and then we discover later on that they develop strabismus. Particularly, we have to refract these patients and make sure if they're hyperopic or not. And definitely, I would follow him up at least after 3 months.
Well, I agree with you that even when you see a pseudostrabismus, and that's a good message to the audience tonight, if you see a case with pseudostrabismus, don't discharge the patient, see him again, and I think every pediatric ophthalmologist would agree. But then, Maha, what would you tell the parents? I mean, he has nothing, yet I have to follow him up. They're going to ask why follow up, or you tell him he doesn't have anything. How would you say? What would you say to the parents in this situation?
I would say maybe like you're seeing something that I'm not seeing, and maybe he's like very well controlling his strabismus right now. So to make sure it's better safe than sorry, actually.
Good. Ajay, do you now, and let's look at the refractions. Again, you don't see the strabismus. You try to elicit it, and you cannot see any esotropia, whether for far or for near. And you have a refraction of a +6. Would you prescribe that and assume it's a refractive esotropia that you cannot see it? Or would you not prescribe that? And to extend the question further, if you see a child complaining of strabismus and you cannot see the strabismus, what are your cutoffs where you prescribe refraction or you do not prescribe refraction?
So one of my first questions would be, is the family noticing intermittent or constant esotropia? I mean, if they really feel that the child looks esotropic in side gaze or very often, or they show me a picture where they say, here is when he's looking esotropic and it is showing aligned corneal light reflexes, that, you know, steers me a little bit more towards pseudostrabismus. On the other hand, if they're saying the strabismus is intermittent, then I want to give it more thought that maybe the child is just very well controlled in the office at this time. And to answer your question about the refractive error, I would give the parents the benefit of the doubt with a +6 that there is quite possibly something an intermittent accommodative esophoria going on, and I would lean towards prescribing for that refractive error for a +6 and parents' reports of symptoms. General cutoffs for me would be in this scenario, where there is a family report of intermittent strabismus, I think the general cutoff would be, you know, really probably 3 or higher. Otherwise, if there's no report of strabismus in a child of this age, I think my cutoff would be higher, 5 or more.
You're aware of a PEDIC study that was published recently about cases, children with refraction between +3 and +6 who do not have esotropia, and whether prescription would prevent them from further complications or not. And I think the conclusion of this study was that prescribing for children between +3 and +6 a refraction does not really help if you don't have esotropia. Do you rely on this study in your decision to prescribe glasses in this age group? Or you still would prescribe glasses in this zone of +3 to +6 with no esotropia?
No, I would, you know, that some of that can be the family's preference. So yeah, I would go along with the data from that study that less than +6, it's not obligatory to wear glasses if the family's not noticing esophoria at this age. I think school age would be different. I do worry about the child losing interest in reading and near activities with a refractive error over 4.
Mm-hmm. So still, you don't stick strictly to the recommendations of the study. Dr. Akmal, you practice in Egypt, where we practice, And Ajay says something good. I don't feel I see that in my practice often. I mean, when you ask the parents, what is the direction of the strabismus that you see? Is it esotropia? Does the eye turn in or turn out? Do they usually describe that properly? I mean, if they say it turns in, you see esotropia. If they say the eye turns out, you see exotropia. Well, you do not usually trust the description of the parents. What do you feel when you talk to parents about this?
For me,
Yeah.
because I didn't, yes, it's very important that you can examine the child and he has intermittent exotropia. During the examination, he is all the time is controlling. If the parents, they are saying that it is intermittent toward outside, I think I will believe, believe the parents. But for the inward deviation, I ask them actually if they are seeing the esotropia toward the side gaze or at the primary position. So the direction of the squint is very important as a key for the question. And I want to tell you about the +6 refraction.
Yes, please.
Yeah. Yes, I'm stick to the rule that even the child has 2 years or more has between not +3, but if he is more than +4 up to +6, this +6 is amblyogenic factor, bilateral amblyopia. And I have few children that I prescribed for them +4, I underact the +6, and then they are transformed into esotropia without the glasses and orthophoria with the glasses. So it is important that +6 is already amblyogenic, bilateral amblyogenic.
It's amazing.
So
yeah, I agree with you. I mean, although we have this study and I direct everyone to reading it about type between +3 and +6, it seems that a lot of pediatric ophthalmologists really stick really to the recommendations of the study. And I see where that's coming from. Maha, would you prescribe, would you ask for an examination under anesthesia or any further investigations? If you see this child and he's coming back, I mean, some of the children, you see them once and twice in office and they're still complaining. You examine them once and twice, you don't see anything, no refractive error. When would you decide, like, okay, I'm going to do an examination under anesthesia or I'm going to ask for an MRI? Would you never do that as long as you don't see anything subjective?
Actually, I rarely do examination under anesthesia if the patient is very cooperative and I can see the fundus very clearly and I can do a reliable refraction. Because what will I see more in an examination under anesthesia? And thus, if the patient is uncooperative, I would do examination under anesthesia. But regarding to imaging, if I'm suspicious that the optic nerve has a problem or like the macular reflexes, I'm not happy with the macular reflex, I would go for further investigations such as VRG, VAP, and imaging.
So you do that sometimes. Well, before we leave this case or situation, I would like to give my quick insight about it. Often enough, I've seen cases like 2.5 years old, 3 years old, coming complaining of strabismus, and by all examinations, I don't see anything. What I do is I follow up. I think most of you would agree that we should follow up these cases. And a good deal of them end up by showing an intermittent XT that I could not elicit on the first examinations. Sometimes it's not helpful. In later examinations, I could elicit and see the intermittent XT, or it turns out to be a refractive esotropia that was not very evident at first examination. Sometimes you have a refraction of a +2.5 or a +3, not enough to prescribe unless you see the esotropia. And the parents describe the esotropia, but I'm really reluctant to prescribe it unless I really see it. So I would sometimes say, I see nothing. I put a question mark, maybe intermittent exotropia, maybe refractive esotropia. I'd say like 50% of these patients, my patients that I cannot see anything on the first examination, end up by one of these. Most of them will be intermittent exotropia because that's the most elusive of them all. That's the one that's really very difficult to grasp. And on some days, the child is really fusing, can break that fusion. It's a good control, although the parents describe it. I think we're going to move on to the next situations. Maha, do you have any questions, any comments before we leave this?
I would just like to add something about the +6 in patients with +6, when do I decide whether or not to prescribe glasses according to if there's a difference in visual acuity between both eyes. Also, if there is an accommodative lag. I try to do a dynamic retinoscopy, see the difference in retinoscopic reflex between far and near. And if there is a lag of accommodation, then these patients are at risk of developing esotropia. So this is my cutoff point when to prescribe or not.
Okay, thank you, Maha. Now we move to the next case, or the next, what we call a situation, not a case. Okay, on a regular day in office, you see a 4-year-old child with a refractive esotropia. The right eye is a +3, the left eye is a +4. With the left amblyopia, again, everything looks very regular. Visual acuity is a 6.6 in the right eye, that's +3. The left eye is 660, the amblyopic eye, the left eye 660. So I agree that most of us would agree that we do a full-time spectacle wear, we give them glasses, and patch 6 hours a day. I think most of you would agree 6 hours a day. Maybe some would do a little bit less or a little bit more, but we do patching 6 hours a day and follow up in a month or 2 months or 3 months. I think most of us would do that. We're expecting improvement. So after 2 months, parents come and say, okay, we've been patching 6 hours a day, wearing the glasses, you measure the vision, and it is 660 with no improvement. I've come across this situation. I'm sure everyone in this panel experienced enough to have come across this situation. And we start by Dr. Akmal. If you face this situation, what's your first impression and what do you do in this? How do you handle this situation?
Yes, it's 4 years old. Most of the children below, or 4 years old, they don't stick to the patching, especially 660 and 6.6. So they don't patch, actually, but the parents will swear that they are patching the child. I think 6 hours per day as a start is very long for the child. So for me, I start maybe, I will ask the parents to patch as small as half an hour, but not more than 1 hour, that the child can obey our order. The second, because most of the parents, they will insist that they are patching more than 6 hours, but they don't patch at all. This is number one for failure of amblyopia therapy.
You suspect that the compliance is not good. That's your first impression when you have failure.
Yes.
Okay.
So to handle the child gradually, 1 hour or half an hour for a longer period is better than 6 hours per day for a short period. If I follow up the child more than 6 months and the vision is still below or 660, maybe I will shift to penalization with optical fogging, and I will remove the glass of the 6.6. Me will help.
Okay, so when you patch for 1 hour, you think you're saying that's like the beginning, 1 hour, and then you try to increase it to 6 hours, or you think 1 hour would give the same improvement as 6 hours in this situation?
Yes, in my practice since 1994, I shifted after my fellowship in Germany for 1 hour per day, not exceeding the 1 hour, and I got the same result as long time patching. So my method is only 1 hour and up to now.
That's interesting. Not the common practice that people do, but we know you're experienced enough to learn from you, Dr. Akmal. That's why we have you with us here. Ajay, how do you handle the situation? I mean, you have a 660 in one eye. Parents say they're compliant. What's your next step?
Yeah, I would echo Dr. Akmal's input about I probably wouldn't start with 6 hours. I typically start with 2, and I'll even tell the family, don't do 2 on the first day, do 10 minutes, or just let the child put the patch on for a minute. I mean, you've got to ramp this up slowly. There's a big behavioral angle to patching therapy that we have to educate parents about. And, one of the principles is to just slowly ramp it up and increase positive reinforcement with tablet devices or snacks or attention from a parent during the patching time. I've got a full sheet of behavioral strategies to help make that more acceptable. Another good one that I think helps for young children is knowing how much time is left. So having a timer that the child can see. But I start with less patching. I'll tell them to build up at the first visit. The instructions would be to build up to 2 hours a day, and then at the second visit, I will, if we're seeing improvement, I'll just keep at that. But once we plateau, then I'll encourage them to do more hours.
Okay, then if they're patching, whether 2 or 6, or they're compliant, and you still see no improvement in vision, what would you do?
Yeah.
Keep patching or ramp up the patching? Do what?
Yeah. So once you tease out, if we're assuming that they are compliant with that patching time, I think there is still some consideration to give to atropine. I know in the studies we all consider it to be equivalent to occlusive patching, but it's just a different way to do the therapy, and I think it's worth a try. So I would talk to the family about that approach.
Okay, so you would still try to reinforce and do more amblyopia treatment, 6 months passed and still no improvement. You would still do more patching, or just give up the whole thing and say that's the best you can get out of this eye?
Yeah, and I should say,
we do see that.
Certainly. And I should say, even at the first follow-up, if we're seeing no improvement, I think it's certainly worth rechecking the refractive error and rechecking the fundus. You miss an optic nerve problem or some type of retinal problem, or you have the wrong refraction. So that, I should have said from the beginning, is something we want to recheck if you're really seeing no movement on the vision. But, if it has been, if we're compliant, no fundus abnormalities, then I think it's worth considering what's the situation here. In this situation, a 1 diopter of anisometropia in a 4-year-old, you wouldn't think that the amblyopia would not budge at all. So that would push me towards doing some additional investigation. It might be an OCT of the macula. Imaging, I'd probably want to hear more about a full medical history and neurologic symptoms before subjecting a child to a general anesthesia for an MRI. But I would be certain that would be on my mind if the amblyopia is not budging with only 1 diopter of anisometropia.
That's anisometropic and strabismic. That's a combined amblyopia. You see there is strabismus and anisometropia as well.
Yes.
Think that would not cause such resistant amblyopia to treatment?
No, sorry. If the strabismus, and then if it's been constant strabismus, then I think it's also worth considering. Has this been constant for 4 years or since infancy? That's a lot of time that eye has been ignored. So it's possible the amblyopia could just be refractory. I certainly think that's possible in this situation.
Mm-hmm. Maha, sometimes, you get the parents saying, okay, doctor, maybe it's not amblyopia. It's not improving. We did the patching, we did everything. They feel they did an achievement doing this patching. Maybe it's not amblyopia. So you might want to consider doing an MRI or an OCT or a VEP or examination under anesthesia to look more carefully. When would you do that? Is it on the first examination, second examination with no improvement? How would you advise our audience who don't practice a lot of pediatric ophthalmology? When would you see a case of amblyopia and you think, okay, maybe that's not amblyopia, maybe I should investigate further, and what investigations you should do?
There are very many things that may cause, like you look at the fundus and you see a normal fundus, like a subtle maculopathy, optic nerve hypoplasia. Sometimes it's misdiagnosed or underdiagnosed. Also, like a cone rod dystrophy or a rod cone dystrophy. All of these things you can diagnose them with an ERG or a VEP. The pattern VEP is like for the optic nerve until the visual pathway. And for the retinal problems, we do the ERG. The full field is for like a diffuse retinal problem. If there is a macular problem, we would do the multifocal ERG.
Okay, and you would order them if you see 6 months of no improvement or 3 months of no improvement. When would you order them?
First of all, definitely I would re-refract the patient, because even a very minor astigmatism would cause, because the patient amblyopic eyes hypo-accommodate. So I would make sure the refraction, I would not undercorrect the plus. I would definitely prescribe the cylinder. And after all of this, and I'm sure that the patient is actually patching properly, not over the glasses, under the glasses, because they could be peeking above the glasses, then I would do further investigations.
Well, this is actually, this case that I was just described is one of my cases. And I see a lot of this, and my take on this is what Ajay said and what everyone said here, that first thing, I would revise everything that I did. Refraction in children is very tricky. Sometimes we miss astigmatism, or we don't do very accurate refraction because the child is not cooperative. If you don't see improvement and you think it should have improved, because some cases we know, I mean, you see an 8-year-old child with amblyopia that's been there for so many years, that's okay not to improve. But if you see a 4-year-old with a recent strabismus and recent amblyopia, I mean, they should improve. If they don't, I would revise the fundus, maybe a small hypoplasia that you missed, revise the refraction after checking the compliance, of course. And if everything is not, everything is not adding up, I would order an MRI or an OCT. I mean, don't hesitate to order that if things don't seem right. Before we leave this case, I mean, you see this child, they have amblyopia, they have strabismus. This strabismus is combined, anisometropic and strabismic. The parents would ask, and I'm sure some of the doctors listening to us today would ask, okay, they're not improving. Maybe if we fix that strabismus, that would help improving the amblyopia, because the eye will be aligned and will be looking through the glasses most of the time. So maybe if the child is not improving with the patching or the atropine or the combination thereof, maybe you would do the surgery and this would help the amblyopia to improve. Dr. Akmal, do you think in this situation you would advise parents, amblyopia did not improve, so you would say, let's do surgery, this will help the amblyopia to improve, or you would insist on working on the amblyopia until you're done with it and then moving to surgery?
No, I don't think that presence of the strabismus is helping with occlusion. I will help the amblyopia, but I interrupt the patching to do the surgery to encourage the child to be compliant with the patching, because the child, I think, is frustrated from his figure. So I start to, after 2 months or 3 months, to help the psychological state of the child, and then continue with the patching. I tried this for most of my patients, and I succeed to improve at least 2 lines. So after 2 months, I will go for the surgery, and I will insist that after the surgery, I will continue on patching. I think it will help. Theoretically, it will help, because the aligning of the eye will be all the time. But it's not the case. I don't think that only the surgical correction of the strabismus will improve the amblyopia.
Ajay, what do you think? I mean, the parents, I had the parents saying, doctor, we patch the eye 6 hours so that the strabismic eye would be used. If we align the eyes, the strabismic eye would be used all the time, not only during the patching, which seems to make sense. I mean, the eye is isotropic, and then if you fix it, it's looking through the glasses most of the time. So would you expedite strabismus surgery to help the amblyopia, Ajay, or you would wait on that?
No, I will start this. As you said, it's theoretically long.
Yeah, okay.
But in not.
Ajay?
Yeah, it's a tough question, and I don't think this has been definitively answered. I think that the classic teaching of treating the amblyopia first, I I don't think it's necessary. There's a lot of arguments to make for that case in terms of follow-up. A family is likely to continue following up with you as long as the child's eyes are crossed. There's the practical side of that. But I do worry a bit with, if you're really not seeing movement on the vision, and, again, you've pursued re-refraction, any appropriate workups, and the amblyopia is just not budging. I think it's worth changing gears and trying the strabismus surgery. It's going to need to be done at some point. I think that it keeps the family engaged. I have, in my practice, I do that, and I don't know if I've consistently seen a vision improvement. I certainly agreed with Dr. Akmal that you have to counsel the family that we will still need to patch afterwards, but patching might be more effective afterwards is sort of how I phrase it. So I think it's worth a try. I do it if we're not seeing movement, and I've seen the family commit to patching, but they still need to patch.
Okay, so we seem to have kind of an agreement here that we do a lot of patching and amblyopia treatment, and after some time we do the surgery and we assume it will help. None of us have any proof that it will help, but that's the only thing that you have to do. Align the eyes. We do see some improvement, and I don't know if this improvement comes from the strabismus surgery or from the continued patching that happened after the strabismus surgery. I don't think there's any literature out there to answer this question. But we do agree all that at some point we'd have to do the surgery before even finishing the amblyopia treatment. Maha, do you have any comments from the audience that you would like to share or answer?
Dr. Islam Shireen is asking, it's just a comment that he would go from 6 hours to 2 hours about the previous case. And Dr. Ahmed Chalabi, he was asking about this case. Would one diopter of an isometropia cause this dense amblyopia?
Well, one diopter of an isometropia can cause amblyopia. Maybe not that bad, but in this case that we have here, that's not only an isometropic amblyopia. It's an isometropic and strabismic, so what we call a combined mechanism amblyopia. And I would also want to say that the one diopter of difference, if it's on the myopic side, is different than on the hypermetropic side. So if I have a -3 and a -4, it's very unlikely to have amblyopia. But if you have a +3 and a +4, it is possible to have it. So yeah, +1 can cause some amblyopia. So time is up with this case, and we move on to our next case. That's even a more regular scenario that you see every day. Parents coming in with a 3-year-old child. They think their child doesn't see that well, or maybe they have a brother or a sister that doesn't see well. And they say, I would just want to check our child's vision. So normally what we do is we do a cycloplegic refraction, and we usually prescribe numbers that are a little bit different from the cycloplegia that we get. That's our common practice. And we would have different points of view about how to prescribe different cycloplegia. We're going to come to that. So I'm going to put 4 case scenarios here for our panelists to discuss. And these are the numbers. And the parents come back after doing the glasses. They come with this complaint. My child does not like the glasses, and she does not wear them at all. You check the glasses in your lens mirror, and they're pretty correct. You revise your refraction is correct. So the child just does not like the glasses. We have the first patient here, as we can see, he's a hypermetrope, a +7. There is no esotropia, so we cut down on the +7, just give a +5 or something, cut the 2 diopters. Some people cut 1 diopter. The second patient is a myope, a -6. Some people will prescribe a little bit higher to account for the tone of the ciliary muscle. The third patient has a -1 in one eye. That will have the comment that by Dr. Ahmed Chalabi. But then now we have this situation here we're going to come to discuss, and you prescribe this -1 in one eye. And the fourth case is kind of a high cylinder. If these patients wear their glasses, that would not be a problem. Now they're not wearing their glasses. They come back. What would you do? Now we're going to start with Ajay. If you can go over these situations and tell us your take, what would you do in this situation?
No, I think what you prescribed here is appropriate. If the child is resisting, I always like to make sure that the fit of the glasses is appropriate. Some opticians, if they're not experienced in fitting young children, they may put an older child's frames, try to bend them into place. So it's really important that the frames be comfortable for the child to accept them. So assuming that's the case, I think some of the options here for the hyperopic child, one of the first things I would consider is, for patient 1, I would consider atropine. And my practice is, what I would explain is that the child needs to relax his or her own accommodation in order for the glasses to work. And so I'll ask the family to use a drop of atropine in each eye at bedtime, and the next day to offer the child the glasses. And sometimes that's all that's needed, is one time. And I'll say that, you will find the child will more readily accept the glasses for the next 2-3 days. And if the child starts resisting again, then you give another drop of atropine in each eye at bedtime. So the atropine is PRN, glasses non-compliance at bedtime. I've had some success with that for the hyperopes, for the high hyperopes. For the astigmatism, that's the other one that stands out here, patient 4, I think that you could give consideration to giving less than the full amount of astigmatism. Sometimes that can be difficult to adjust to. So I would consider in that child giving half of the astigmatic correction as a bridge. So once the child is reliably wearing half the correction, half the astigmatic correction for a period of, not very long, 2 months, then I would increase to the full.
Maha, do you consider giving the glasses gradually in these cases, like the myope or the astigmatism or the hypermetrope? I mean, if they're not happy with the -6, this is again a very common situation. So I was not happy with the -6. Do you give him like a -3 and then up that later to -6? Would you do that on the first visit, or would you try the -6 and then see if they're not happy, you cut down? What would you do with the hypermetropia? Do you give it straight away? Or you just give it in steps? What do you do in this situation?
First, I'll start with the hypermetropia. Usually, if there is no esotropia and I'm not worried that the patient is deviating, then I would do it gradually. Myopia, usually they do tolerate, so I would start with a -6, but if they're insisting that they're not wearing the glasses and they cannot tolerate it, maybe I would just go a little bit less, and then, but in myopia, usually I move faster to give them the full correction.
Good. Dr. Akmal, now we have a very complicated question for you.
Yes.
Okay.
Because for the first patient.
No, I have a kind of a tricky question in this situation.
Yeah.
The parents ask something. Some of the parents ask something. Okay, they're not very happy with the children wearing these glasses, and the parents say this question: okay, doctor, what if he doesn't wear the glasses? What will happen if he doesn't wear the glasses? I mean, my son is 3 years old. I would like to wait until next year. If he, I mean, he's saying, they say, I mean, he sees well, he plays around with the kids, and I don't see any issue. Is there any problem if I postpone wearing these glasses until next year? How would you answer this question in each of these patients? Would you tell them it's okay not to wear the glasses until next year? Or would you say, no, you have to wear the glasses because if you don't wear them, this and this and this will happen? How would you answer this question?
Yes, this is the key. This is the key for everything, that you should tell the patient what is the risk if the child does not do the procedure, whatever the procedure, if it is even eye drops, what is the risk if I will not give the child eye drops? The surgery, the same. The issue is, what is the risk if the parents or the patient did not do the procedure that I asked? So, for the first case, the child with the high hyperopia +7, +8, I want to ask you, what is the dry type of refraction? I think the dry without any cycloplasia might be the same, or a little bit +6, +7, will not be more than that, because the patient has no squint, so he has no accommodation. So if I didn't give the child the glasses, he will adapt on this blurred image, because he should stop the tendency for esotropia, and he will get bilateral amblyopia. And I explained to the parents that if I am the teacher and I let the child to speak the language falsely, he will keep on that all the years. So I should learn the children the proper vision. For the patient number 2, they are the most happiest children, because when they are wearing -6, they will see everything far very clear. Because when he is trying to see clear, he will come near to the object. So the second patient will be happy with the glasses. For the third patient, if the parents ask me, I will tell them, okay, don't let the children wear the glasses, because it's only -1. And on the school children, I will catch up the difference of -1, as you said, it's not amblyogenic. The fourth patient with the high astigmatic, it's the same like the high hyperopia. The child will adapt on the equivalent sphere, which is -2. It's already blurry vision, and the astigmatic patient has no distance to see clear vision. He has no power of accommodation to see clear vision. He has 3 types of foci, so he will depend on the equivalent sphere. And we process the brain that the -2, it's the proper vision, which I name it as a bilateral amblyopia. And if the child will not wear the glasses by the 3 years old, I will tell them that at time of 6 years in the school children, all that the best corrected vision will be 6/9 or 6/12, like 0.8 or 0.7. This is the best corrected vision for that child if he is not wearing the glasses early.
Thank you for that detailed answer, Dr. Akmal. Really, I love this, the full of details. Ajay, let's see if the parents ask you one question, a direct question, say, okay, if you don't wear the glasses, is the vision going to get weaker? Yes or no? You have to answer this question in each of these situations. Because they seem like the parents, they're not going to be compliant. They don't want to put these glasses on. So they ask you, does the vision get weaker if we don't put these glasses on for the next year? What would be a simple answer that you will tell to the parents? So this is for our audience to say, how do you handle this situation with the parents? Although we know the answers as doctors, I mean, what would you say to the parents? Yes or no? And the brief explanation that you would say in each of the 4 situations.
Yeah, I mean, I would say the vision's not necessarily going to get weaker, but it's not going to get any better. And I would also emphasize that whatever acuity we're getting in a 3-year-old may not be the child's true visual acuity. We might be using Allen figures or Leah symbols, which may be overestimating the acuity, especially if we're using single optotypes. So I would emphasize that the vision may actually be a little worse than what the child's measuring and where the child is functioning, because the child's demands are going to increase, the visual demands are going to increase, and normal development is that the acuity will improve. But if he doesn't, in most of these scenarios, with the exception of the third one, without the glasses, the acuity won't be able to improve to meet the increasing visual demands of school age.
Mm-hmm. So if you look at patient number 3, again, for the comment that we had earlier, a -1 in one eye doesn't really cause a problem. But if this was a +1, we would hear different opinions about it. One of the things that I struggle with the parents, and I'm sure everyone sees that, when you see a parent coming in and saying, we've been following up every year, we wear the glasses every year, and my child is getting worse every year. And they're referring to their myopia progressing from -2 to -3 to -4. And they always confuse the myopia with the visual acuity. And I always struggle explaining that to the parents, to what does it mean that, how do you say, doctor, that my child is improving, although I get a higher prescription every year? So I keep describing them, okay, that's myopia increasing, and that's different from the visual acuity. I always struggle with the parents with that. Maha, you, in these situations, you don't have any subjective visual acuity. You can't measure visual acuity. And you put on the glasses and the child is not wearing it. So you might consider that there is something else causing the child not to see well, That's why when he puts the glasses on, he's not improving. I mean, you see a -6, he should put on the glasses. He should be very happy. That was we know. So if you have someone who puts on the -6 and he doesn't really wear it, you might think maybe he has a retinal problem, maybe he has an optic nerve problem. I can't really measure the visual acuity, so I would ask for more investigations. When would you know? When would you do that? At what situation would you say, okay, maybe it's not only a refraction problem, and I would ask for an OCT or an MRI or something else?
Actually, I would put first of all the the 20 diopter base down prism to see if the child in front of each eye, and to see the child if there is any movement. If that happens, the child is seeing, and I'm not sure really about when to really order the OCT.
So not being compliant with the glasses is not enough to order an investigation. You have to see something more than that.
Because young children, it's very difficult to do OCT. That's why I was reluctant in answering the question. I don't know. Do you do OCT in very young children? I don't.
No. I mean, we really try to. I mean, everything is difficult with children. I mean, refraction, wearing the glasses, knowing if they're happy or not. Everything is difficult. That's why there are pediatric ophthalmologists and there are other ophthalmologists. I mean, yeah. I mean, for me, I mean, if not being compliant with the glasses is not enough to do investigations. But if someone is not seeing well, like a -6, and he's not compliant with the glasses, and he's still a -6, and there is a visual complaint, maybe I would consider doing investigations. And my number one investigation would not be an OCT; it would be an MRI. And I've had a couple of cases where I found a craniopharyngioma or something pressing on the optic nerve. Maha, before we leave this case, we have like 2 or 3 more minutes left in this case. Would you like to select some of the audience comments to look at and have some of our panelists discuss it?
Okay, Dr. Wael is asking, would you prescribe a full cylinder for a younger patient?
Dr. Akmal, would you prescribe a full cylinder for a younger patient?
Yes.
Any number, 6 cylinder, you would still prescribe it?
Cylinder, no.
Cylinder. Okay, Ajay, full cylinder for the younger patient?
Yes, to start.
Okay, and for me, yes, and I think everyone agrees.
I agree.
So
Our next question is, what is your cutoff point when to do cycloplegic refraction for a young child? When do you do the autoref without a cycloplegia?
Well, that's a good question. I mean, if you see a child 7, 8, 10, 12, 16, Dr. Akmal, when would you say, I'm not going to do a cycloplegia, I'm going to refract this child doing manifest refraction only?
Not less than 14.
Anyone less than 14, you do cycloplegia?
Yes.
Good. Ajay?
You know, are we talking about new patients? I mean, if it's established patient I know who's mildly myopic, then I think, you know, if you know the trend over time, and there's moderate myopia that's not too difficult to do retinoscopy or manifest on, I'll do that. But for the hyperopes less than 10 years old, I would probably do cycloplegia for all them.
Okay, so anyway, so if you see a new patient who's 11 or 12, you would not do a cycloplegia?
No, any new patient I would.
Any new patient, 13, 14, you would still do it?
Yes.
Okay, Maha?
I agree, totally agree.
So I guess we have a kind of a consensus here. When you see new patients, we usually do cycloplegia. The only case where I would not do cycloplegia is if I see a new patient, a little bit older, like 5, 6, no, not 5, I would say like 7, 8, 9, no complaint of strabismus, his vision is 6/6, and I'm good enough with my retinoscopy that I can say that there is no hypermetropia that's undetected in this child. That's the only situation where I might not do a cycloplegia. But if you're not very confident of your retinoscopy, I mean, always do cycloplegia whenever you do that. So there's a lot of cases with 9 years old, you put him in the autorefractometer, he reads a plano or a -1 or a +1/2. You cycloplegia him and you see a +6 or a +7. That's very regular. And we can take a third comment from the audience if you have any.
All the comments are for previous cases, so I don't know if you want to move on.
Okay, to move on for the sake of time, We have the fourth and last situation. This is, again, a very, very common situation. One of the most common situations in strabismus is intermittent exotropia. I'm sure every pediatric ophthalmologist office sees a couple or more of these every day. I'm sure every general ophthalmologist, I mean, if you've ever seen children, if you ever see children, you might have seen intermittent exotropia, or the eye deviates outwards sometimes. It can be very often, it can be rare, but I mean, it does happen. And this is a very common condition. And although it's very common, it's one of the most controversial situations in strabismus. And you're not going to see a lot of consensus now when we talk about it. I would talk to Ajay first and say, when do you operate for intermittent exotropia? And every one of the panelists is going to have to answer this question, because we're going to have here, I think, 4 different answers, just to show you the kind of controversy about this topic. And I'm sure we're going to benefit from this controversy. So Ajay, I have a slide for you. When you want me to show that slide, I will. So when would you operate for this intermittent exotropia?
Can you play your video once more? Just you're speaking about this case specifically?
No. I'm just speaking about intermittent exotropia, not particularly this case.
Okay.
I'm just speaking this case to show that this is intermittent exotropia, not particularly this case.
So, you know, I use the Intermittent Exotropia Office Control Scale developed by Holmes and Mahoney. You can put that slide up if you like. And what I like about this scale a lot is the top 3, 5, 4, and 3 is referring to spontaneous exodeviations. You know, constant, number 5, 4 is more than 50%, less than 50%. And then 2, 1, 0 is intermittent deviations that you can only bring out by your alternate cover test. So this really helps me in conjunction with what families are seeing at home. It also helps consistency between myself and my staff, and also between examinations, so I can get a sense of the trend. And your question about when do you operate, I think basically if I'm seeing, and by the way, you use this scale at distance and at near, and basically if I'm seeing grade 4 at distance and near, that to me is a child that's at risk of potentially losing binocularity. And so that's when I think there is a medical indication to intervene, assuming we've tried already the conservative measures of patching and over-minus glasses and vision therapy. Below that, I think 0 and 1, I'd be very unlikely to intervene. But in 2 and 3, that's where it gets down to kind of family preference, where I'm open to intervening if it is causing some social distress to the child or the parents. And so those are my breakpoints here using this scale.
Dr. Akmal, when would you operate for intermittent exotropia?
Yes, first of all, I am on the other bank of most of the doctors. I will clarify, first of all, the intermittent exotropia is a very nice situation for general ophthalmologists, because anything you will do, you will get for the early postoperative a very good, more than 95% corrected. Whatever you do, 3 millimeter recession, 4, 5, you will get, because it is intermittent. So for me as a strabismologist, this is the very bad situation, because if you are working early, you will get, I think, 70 to 75% exodrift. Again, it's a very high instance. And if you work early, you will get 15% esotropia. So your question, the first, what I said, it's the key. If the parent says, what is the risk if I will not do the surgery? What is the risk? So my indication to do the surgery upon the first embarrassment of the child, because the psychological state. But if no one from his correspondence noticed that the child is squinting, no harm, he will not lose any function. And I am insisting for all the audience that if the child will lose the binocular vision For intermittent exotropia, if you are calculating actually that the child is deviating 1 minute, 60 seconds, it's very, very long. And it is this 1 minute, it's 50 times per day. It is very frequent. So it is a 50 minutes during the 24 hours. It is not efficient to lose any function because the child will sleep at least 6 to 7 hours and he will not lose any speech problem. He will not lose any walking function. The only thing that the human being is losing a function is a degenerative condition. Once the function is stored in the brain, will not go. So I will do the surgery when I ask the patient, the parents, there's any embarrassment for the child. If there is any embarrassment, I will do the surgery and I will consider or explain to the parents that the child may have a second step. That's my plan.
Yeah, that makes sense. You don't rely on any scale like one of those scales or the Newcastle scale. Maybe we'll hear from Maha, when would you operate for intermittent exotropia? When you see such a child, and that's one of the very common questions that my colleagues ask me. I mean, they see a child with an exotropia that comes and goes, and they tell me, okay, should we do surgery or should we not for this child? What would you answer your colleagues and the parents in this situation?
I use a similar scale, but quite a different scale. It's called the Newcastle Scale. I ask the parents about the frequency of deviation at home, and if it's like more than 50 or less than 50, and then I do the office exam. The office exam, you ask the patient to look at something at distance and at near, and you do the same thing, which you patch one eye, and then you remove the patch, and you see if he refixates quickly or not. And then it's a long scale, it's like from 0 to 9. And if there is good control in the office and less than 50%, I would not do surgery. But if there is poor control, like if the patient comes in the clinic with the eyes deviating, or they deviate very quickly, I would go for surgery.
Okay, now since we discussed when to do surgery, more often, I mean, in a lot of situations, we get the parents saying the following: okay, you say the child is indicated for surgery because for whatever reason that we saw, I mean, we all discussed now, and you say, okay, I think from my experience, your child needs surgery. And then the parents are reluctant. They would say, okay, doctor, we want to wait on this surgery. We don't feel very comfortable. They would ask you this question: will delaying surgery for this situation affect my child's vision? That's the question number one. Question number two, and Ajay, you're up next on these questions. Will delaying the surgery make its success rate worse if we wait, or should we do it right now to have a better success rate? Because I get some patients saying, okay, we're really not comfortable doing the surgery, but we want to do it because if we wait, the vision might be poorer. Or if we wait, it will not be successful when we do it at an older age. How would you reply to that when the parents say that?
Yeah, I think there's two angles here. I mean, one is theoretically, I think we all think that if an strabismic eye is deviating close, more than half the time, then, there is a chance of permanent loss of binocularity, which could compromise the convergence amplitude that we rely on postoperatively to keep the eyes together if there is damage to binocularity. But I think studies have borne out that intermittent exotropia tends not to change that much over, I think 3 years is the most recent pediatric studies, observational studies of intermittent exotropia. It just tends to not change that much. Binocularity tends not to change that much. Acuity doesn't change that much. So I think generally we can reassure parents that, it's not going to get worse if you wait on it. That doesn't have to factor into your decision about doing surgery now.
Okay, I agree with you, Ajay, and I'm sure everyone would agree. I never mentioned the audience here. Intermittent exotropia, the way we saw in the video and the way you see it, it never, I wouldn't say, I would say almost never, or I would say still say, I'm very confident to say it never causes amblyopia. So if you see a child with intermittent exotropia and no refractive difference between both eyes, and you see a vision that's not good in one eye, that's not amblyopia, look for something else. I mean, I wouldn't. Have you ever seen a case of intermittent exotropia that caused amblyopia, Ajay, Dr. Akmal, Maha? I mean, yeah, it's very, very unlikely to affect the vision. Affecting the binocularity, I mean, just like Ajay said, we would think that this exotropia would affect the binocular vision in the long term. However, studies failed to prove that. I mean, I couldn't really get hold of studies that says, okay, if you wait a couple of years, you get worse binocular vision. I couldn't get hold of such solid studies to prove that. So again, I agree with you that waiting on this intermittent exotropia is not going to affect the child functionally. It's not going to make the vision worse. It's not going to affect the binocular vision. It is going to affect the child psychologically. Maybe in school, he's going to get bullied. And that's a big thing. That's not a small thing. And that's why, Dr. Akmal, I really respect your opinion. You're saying once his peers and his friends at school start noticing it, that's when I do the surgery. That's a big thing for the child. That's not a small thing. So although it's not a functional problem, yet it's a social problem. But if you see parents that sometimes you come to parents say, okay, we don't have a social problem, no one notices it, but we want to do it because we're worried about the vision, we're worried about the binocularity. And you say, no, the vision is not going to affect it. The binocularity is not going to get affected. Dr. Akmal, well, you see a child and you don't decide to do the surgery because it's still too early. What would you do meanwhile? I mean, would you help him with alternate patching, over minus glasses, or just do nothing? I mean, parents would let them follow up every 6 months, and during this 6 months, what would you advise them to do?
So for me, I'm not believing in alternate patching. I am totally against the over minus because it is an artificial thing. The over minus for me, if the child is +3 or +2, I will not give him any glasses. This is the overcorrection for me. Or if the child is +3 or +2 cylinder axis 90, I will give him -2 axis 180. This is for me the only situation for the over minus. But I don't like over minus because it causes headache and it's not natural. So
patching, you don't do alternate patching.
No, I didn't do it in my practice.
Okay, I'm sure we're going to have a little bit of controversy here. For myself, I don't do alternate patching a lot. But I would like to hear the opinion of Dr. Maha ElBasha about this. I know she's a bit of a proponent for the alternate patching. So in a simple words, how do you do it and what benefits do you see of doing an alternate patching for such a child?
I'll tell you when I do it first. I do it when the control is quite good or fair. And I want to give some time for the surgery to happen. And if I'm not sure of the angle and I want to remeasure it, so it's a kind of a temporizing way. How I do it, I patch like 1.5 to 2 hours per day. First, like I patch the right eye for one day, and then I go to the left eye the other day. And that's
alternate. The benefits that you see out of that is?
At least they stabilize. They do not get worse in my hands. Get better or not, I'm not sure, but usually they do not get worse.
Okay. And do you think it's worth the pain going through this patching, the benefits that you get?
Theoretically, it is, because theoretically it does improve the suppression scotoma, but we're not going to go into this.
Okay. We're good friends, so I'm going to tease you a little bit more about this alternate patching. We're on two different sides of the spectrum on that, because we practice in the same city, but we don't do it. I mean, do you think that it will decrease the surgery rate? I mean, if you do alternate patching, does that make the children less likely to do surgery, or eventually it's going to do surgery?
Eventually I'll do surgery. It just buys me time. A child a little bit older, more cooperative. It's just a way, like, instead of telling them I won't do anything, go home.
Okay. You do it just to help them to keep the parents busy.
Yes, exactly.
Ajay, we're going to talk about age in this situation. Parents and other doctors sometimes they say, okay, what's the best age to operate? Or is there a certain age group that you would want to avoid surgery in? Or is there a certain age group that the surgery is good at, intermittent exotropia? Sometimes they do have a cosmetic problem. It's not such a very big problem. So, I mean, we're flexible with the time of surgery. Is age a factor? If you see intermittent exotropia, when they discuss age, they say, okay, age is not a factor at all in your decision, or is it a factor? So discuss age in relation to surgery for intermittent XT.
Yeah, age is a factor in terms of, you know, I think that prior to school age, I think the social concerns are less. And so I'm hesitant to do surgery for, you know, intermittent exotropias that are under fair control, you know, like on that control scale, something like a 0, you know, like a 1, 2, or even 3. In a young child, you know, these are intermittent deviations that are present the minority of the time, because I feel like we don't have to weigh the social concerns as much in these young children. And, you know, there is a small overcorrection rate from surgery. And that's really the harm that we can do to these kids, is if they have an overcorrection, because they're used to fusing their exodeviation. But if they have an overcorrection, I want to be able to manage that so the child doesn't lose binocularity. That's really the biggest risk, I think, in this surgery, not that it happens all that often. So that being said, you know, I like for the child, if I can wait, I like for the child to be at least 4 or 5, so that if I need to use some base out prism in the postoperative period to wait out a consecutive ET, I'm more likely to get compliance with that than a young child, where it could be a real gamble whether that child will wear glasses.
Okay, before we leave you, Ajay, we have a comment from the audience as we're wrapping up now. It's from Dr. Muhammad Fadin. He says, is grade 4 or 5, does grade 4 or 5 in your scale affect the binocular vision?
Yeah, I mean, that's a
yes or no question, huh? You have to say yes or no.
The best answer I can give you is sometimes. I do tend to find that oftentimes that even grade 4 has normal stereopsis. The grade 5, the tropias, I think it's unlike that. Then they're not truly a grade 5 if they have normal binocular vision and you're calling them a grade 5.
Okay, so you're gonna have to answer the next question too, from the audience. Why doesn't exotropia affect the binocular vision? Even though the patient with exotropia, they have suppression. How come it does not affect the binocular vision? Want to explain that?
Well, I think it's it's intermittent. And I think that in general, if you've got some, you know, and we don't know exactly what that number is, but there's a certain minimal threshold amount of binocular vision that you need to maintain binocularity. And I think that number is probably pretty low. I think we all use the 50% because that just kind of feels right, and it's an easy question to ask parents. But the truth is that kids can probably be drifting out far more than 50% of the time and still maintain binocularity during their times they're not tropic.
I would like to add a comment here about binocularity and intermittent exotropia. My first comment is exotropia, intermittent exotropia, does not affect binocular vision. We can go on discussing why for a long time, but with the fact we know it does not affect binocularity. And I think, like you say, if you have like a couple of hours a day where the patient fuses and he fuses for longer times, they will still have good binocular vision. Once you align these eyes, the eyes would lock back in and you would get good binocular vision. So these patients, they do have good binocular vision. And the other reason is intermittent exotropia starts at a later age, not the first year or second year. So usually the very early critical years of life, the child has good binocular vision, and he builds on that by the intermittency. That's why they don't lose it that often. So when you see a case of intermittent exotropia, know that you're dealing with a child at no risk of amblyopia and with a good binocular vision. We do surgery and we're very happy when it succeeds. But one of the things that are very disappointing when you have an exotropia that you do surgery and you end up with an esotropia. The esotropia is usually constant. And then the patient is at risk of amblyopia and at risk of losing his binocular vision. Dr. Akmal referred to that, and we all refer to that, and we know that at this situation, you would do a disservice to the patient rather than doing him service. One of the things that make me very reluctant to operate on intermittent exotropia is that I know that having a consecutive esotropia that cannot be managed in the right time would turn this patient from someone with a good binocular vision, no amblyopia, to someone with the risk of losing both, losing binocular vision and getting amblyopia. That's why you should be careful in doing this. And that's one of the reasons we may want to delay the surgery for intermittent exotropia to a later age where we have more solid binocular vision, where we have less risk of amblyopia. That's why careful with these cases. So I have a last question before we wrap up. It says, when do you prescribe over minus if AC over ratio is high? Dr. Maha, that's up to you. Do you prescribe over minus or you don't? No. And when, and what does that have to do with the AC over A ratio?
I do not do that because AC over A ratio, you prescribe a bifocal. You don't prescribe a no.
Okay. Ajay, Dr. Akmal, anyone prescribes over minus in cases of change high AC over A ratio?
No.
So if you're talking about exodeviations with a high ACA, so these are patients who have an exodeviation at near less than distance, and you go through the 30-minute patch test to make sure it's not just the proximal fusion, and they truly have a high ACA. The teaching I've heard is that those would be good candidates for over minus, that they would be more likely, they have more convergence tone for a small amount of increased accommodation. I think that would be a good candidate for over minus.
Well, thank you, Ajay. Thank you, Dr. Akmal. Thank you, Dr. Ma. Thank you, Dr. Soni. Thank you, everyone. Thank you for the audience. We'd like to keep that webinar short, 1 hour, it's running late. Stay tuned. Next week, there's going to be another episode from the iHub. I hope everyone benefits from tonight's session. I personally learned a lot, and I hope everyone did. Thank you, everyone, and we will see you soon.
Thank you.
Have a good night.
Thank you. Good night.